સર તમે સ્ટાર્ટ કરી શકો છો.
Good afternoon, all. First of all, I welcome our Dean College of Genevieve, Dr. Bora sir, our senior Dr. Madhav bhai, all three speakers, Dr. Yadav sir, Dr. Manan bhai, and Dr. Tejaswini bhai. I welcome you all on this 7th CME of College of JP, which is webinar we are continuously every month doing on 2nd or 3rd Thursday. Last month, we had a discussion about the preventive health checkup and lifestyles. What should be the lifestyle changes which we should do to have a good health? In continuation with this, this webinar is about tumor marker. So, in this topic, we'll be discussing tumor marker, its prognostic values, and its therapeutic influences or therapeutic things which we should know as a family physician and other medical fraternity. So I hope this tumor marker webinar will help us to prevent prevent malignancy or detect early in stage, and this will help definitely to build up a healthy society. Now, our coordinator is Dr. Madhusudan Umarji. He is a family physician from Surat. He is hold so many posts in Surat Medical Association, and he was also Vice President of Surat Medical Association. So over to Dr. Umarji.
Namaskar. Good afternoon, my dear friends. Let us begin by seeking blessings of Ma Saraswati. Ya kundendu tushar har dhavala, ya shubhravastravruta, या वीणा वरदंड मंडित करा, या श्वेत पद्मासना, या ब्रह्माच्युत पंकर प्रबुधिभिर् देवै सदा वंदिताम्, तामां पातु सरस्वती भगवती निशेषजार्यापहा. I once again welcome all the dignitaries and all the doctors who have joined online today for this webinar. Dr. Jaswant Darbar has already given a brief introduction about today's webinar. So I straight away request Dr. Ajit Bora sir, Dean College of General Practitioners, to say a few words here. Dr. Bora sir, please.
Thank you, sir. Good afternoon to everyone. Respected Dr. JPG Darbarji, our Director of Studies, IMSGP Gujarat branch, our senior member, Dr. Madhavji Desai, Dr. Madhusudan sir, and all the senior members of Gujarat State branch and the Gujarat State faculty, and respected eminent speakers of today's CME, and all the participants. I bring greetings to all of you from IMSGP headquarters. All of you are aware that IMSGP is always focuses on updating and empowering the general physicians and family physicians of the country by taking various programs and various courses. And I have been observing with delight that Gujarat State faculty is very active and very aggressive in promoting this agenda. This is probably the 7th virtual continuous medical education program of the Gujarat State faculty. And they have organized a very important subject like tumor markers, with very relevant topics like covering hematological markers, biochemical markers, and also exploring the molecular levels. Tumor markers play a very important role in the diagnosis, prognosis, management, and also evaluating the outcome of management or response to treatment, not only in cancer, but also in many cancer-like situations. And I have no doubt today's participants will be immensely benefited from the deliberations given by the eminent physicians and speakers. And also, it will certainly enrich our knowledge and benefit in our practice. Long live IMA, long live IMSGP, and long live IMA Gujarat State branch. My thanks to all of you and giving this opportunity to come virtually in this important academic agenda. Thank you very much.
Thank you, Bora sir, for your nice words. Now, may I request Dr. Madhav Desai for a few words here, please.
Welcome, Dr. Satyajit, for your kind and blessings, and Dr. Darbar and all the office bearers. I think it's really a very, very welcome speech by Dr. Bora that has started the ball rolling. And as Dr. Darbar has rightly said, that we already had discussed in the previous episode about the preoperative checkup. So, in the same context, we are talking about today's topic of tumor markers. So we know that these days we get so many profiles of different kinds from different organizations that for a family physicians as well as the lay public, it is very difficult to decide which particular health checkup profile to be picked up. And here, what is important from today's discussion is that we need to know when to ask and when not to ask for a particular tumor marker, because that might unnecessarily increase the anxiety of the patients and the relatives. So I'm sure that they are going to focus about both the importance of doing it at interpreting it and not overreading the particular tumor marker. With this, I hand over to Dr. Madhusudan for further proceeding. Thank you.
Thank you, Madhav Bhai, for your kind words. Now let us start learning a few new things. For that, I would like to introduce our first speaker, Dr. Tejaswini Dhote. She is a distinguished pathologist for her expertise in clinical pathology and special tests. She will be speaking on biochemical tumor markers. She is a consultant pathologist at Sterling Accuris, Ahmedabad. She is a MD in pathology from Nair Hospital, Mumbai, and earned a management degree in hospital and healthcare management from a prestigious Indian Institute of Management, Kolkata. Wow, that's great. She works with pathology laboratories and hospitals to provide leadership in driving business performance forward in the field of pathology and hospital management. She possesses excellent investigative skills and a better understanding of pathological processes. She carries an exceptional quality objective at workplace, and as an auditor for ISO 15189-2007, she has successfully led and guided laboratories through audits and inspections. She participates in multiple initiatives to improve services in pathology laboratories and healthcare institutes, and is a frequent presenter at workshops and conferences on issues related to advances in pathology and its related services. We are really honored to have you here, Dr. Tejaswini. Please go ahead with your subject. Thank you.
Thank you, Dr. Madhusudan, for your warm welcome. Am I audible?
Yeah.
Yeah. And thank you, CGP IMA, for giving me this opportunity to present a topic which is really needed to discuss among the general practitioners, because this is mainly handled by the oncologist, but these reports are always viewed by the general practitioner also, because the whenever abnormal on any report comes, the patients have the habit to show that report to their family physician first to get some information from them, because they trust them the most. So I'll start my presentation.
Of course, ma'am.
Is my screen visible now?
Not yet, not to me.
No, ma'am.
Just try. Now? Is it visible now?
Yes, it is.
Yeah.
Thank you, everyone. So we'll discuss. I'll be discussing more about this tumor markers, biochemical tumor markers. So biochemical tumor markers are substances that are synthesized and released by the cancer cells or produced in host in response to the cancerous substances. So what are the criteria for a tumor marker to be the best or the ideal? So it should be present in pronounced and present or produced by the tumor itself. It should not be present in healthy tissue. The level should be at the minimum level in healthy subjects and in benign condition. It should be specific for the tissue. The level should be in proportional to the size or the activity of the tumor. Half-life should not be very long. It should be present in the plasma at detectable level, even though the tumor size is very small, to detect the cancers at a very early stage. It should be useful both in prediction of the presence of tumor and recurrence of the tumor. But as usual, the ideal markers doesn't exist. So what are the substances which can be the tumor markers? So there are few oncofetal antigens. Oncofetal antigens are the substances that they are secreted at the intrauterine level, but they disappear after the birth. But few tumor markers, they are again expressed. So in this category, we have CEA and alpha fetoprotein. In hormones, we have beta HCG and calcitonin. In carbohydrate epitopes, we have CA125, CA15.3, CA19.9. We have enzyme like alkaline phosphatase, prostate acid phosphatase. In proteins, we have beta 2 microglobulin and thyroglobulins. In metabolites, we have VMA. Sorry for the what are the potential uses of tumor markers? So tumor markers are used in screening in general population, in differential diagnosis of symptomatic patients. They are used in clinical staging of the cancers. They are also used in estimating the tumor volume. They are used as a prognostic indicators for the disease progression. They are also used in evaluating and monitoring the success and response to the therapy. They are used in detecting the recurrences and in some cases radio immunolocalization of tumor masses. So this is a very huge topic. So I am covering the common tumor markers which will be encountered in routine practice. So this is the graphical representation. So this is for breast cancer. We have CA125, CA15.3, CEA, HER2 receptors. For stomach and colon cancer, we have CEA. For pancreatic, we have CA19.9 and CEA. For ovaries, we have CA125 and CEA. For testicular cancers, we have alpha fetoprotein and beta HCG. For prostate cancer, we have prostate-specific antigens. And in liver cancers, we have alpha fetoproteins. Lung cancers, we have CA125 and CEA. So these are the common tumor markers which will be encountered. Among these, the PSA is the most common tumor marker, which is encountered by the general practitioners also. So PSA is prostate specific antigen. So this is specific for screening and for detection of early prostatic cancers. PSA is increased in prostatic cancer, but itself it is not effective in detecting early prostate cancers, as it is also increased in other prostatic conditions like benign prostatic hypertrophy, prostatitis. It is also increased in urinary bladder catheterization and urinary tract infections. PSA values are marginally increased even after digital rectal examination and transrectal ultrasonography. So whenever you are ordering a PSA for screening or for detection, for your detection of the prostatic cancer, the blood collection should not be after the rectal examination or sonography. It should be the blood collection should be done before the rectal examination and transrectal sonography. Instead of free PSA, free PSA is raised in both benign and malignant conditions. PSAs are present in two forms: free PSA and complex PSA. So free PSA, the ratio of free PSA to the total PSA is a reliable marker for differentiating prostatic cancer from benign prostatic hyperplasia. If the ratio is less than 25, then it suggests towards the prostatic cancer. So serum PSA levels was found to be correlated with clinical staging, grade, and metastasis. If there is a history of androgen deprivation therapy, then these PSA values has to be considered, as this therapy will reduce your PSA level more than your tumor. So next come the alpha fetoprotein. Alpha fetoprotein is elevated in hepatocellular and germ cell carcinomas. It is also increased in some non-malignant conditions like pregnancy and chronic liver diseases also. It is useful in screening, determining the prognosis, and monitoring the therapy of the liver cancer. Also, it is a prognostic marker for survival. High alpha fetoprotein level at the time of the diagnosis will correlate with the low survival rates. Alpha fetoprotein and beta HCG combined are useful in classifying and staging the germ cell tumors. One or both the markers can be increased in these tumors. Then comes our carcinoembryonic antigen, CEA. This is this tumor marker is secreted by many of the epithelial tumors. So it is not specific, but it has its own importance. So this marker is secreted in colorectal, gastrointestinal, lung, and breast cancers. They are also elevated in smoker and some benign conditions like cirrhosis, rectal polyp, ulcerative colitis, and benign breast diseases. So CEA testing should not be used for screening, but it is useful in staging and monitoring the therapy. CA125. CA125, this is the only defined marker for ovarian cancers, but it is not specific, and this is also increases in other cancers like pancreatic, lung, breast, colorectal, and gastrointestinal malignancies. It is also elevated in benign conditions such as cirrhosis, hepatitis, endometriosis, pericarditis, and early pregnancy. Even menstruation increases CA125. So if you see marginal increase in CA125, then you should consider first the benign or the physiological condition before interpreting it as a malignant marker. It is useful in detecting residual disease following the initial therapy. A pre-operative CA125 level less than 65 is associated with greater than 5-year survival rate than in level greater than 65. So it gives you the survival status. It is important in detection of the risk. Use of CA125 level as an indicator is about 75% accuracy. CA15.3. So this is the marker for breast carcinoma. It is elevated in other malignancies also like pancreatic, lung, ovarian, colorectal, and liver cancers. Some benign breast diseases and liver diseases also increases CA15.3. So again, it is not a marker for diagnosis. It is, but it is useful in monitoring the treatment. Here come a marker, CA19.9. This is the marker for mainly for pancreatic malignancies, but it is also increasing colorectal cancers, hepatobiliary, gastric, hepatocellular, and breast cancer. So there are a few benign conditions also which will lead to the marginal rise in CA19.9. These are pancreatitis, benign gastrointestinal diseases. CA19.9 levels correlate with the pancreatic cancer staging. So this marker is used not for the diagnosis but staging of pancreatic cancer. It is useful in monitoring the pancreatic and colorectal cancers. Elevated level of CA19.9 can indicate the recurrence before the detection of the radiotherapy or the clinical findings in pancreatic and colorectal cancers. So recurrence and staging, these are the two key points for CA19.9 in pancreatic cancers. So this is a this is a small chart showing there are different uses of these tumor markers, and for particular use there are few markers which will be helpful in that in the cancer treatment or your journey in the cancer. Like for screening purposes, we all know males more than 50 years of the age and males with less than 50 years of the more than 40 years of the age with high risk of prostatic cancer, like previous history in the family of prostatic cancer, are tested for PSA. So for screening purpose, PSA is the only known marker. In diagnosis cases, high level of tumor marker may indicate the disease. In this category, we have chromogranin A, cortisol, PTH. The high value of these tumor markers will indicate or guide towards the diagnosis. For prognosis purpose, high level of few markers like CA125, CEA, beta 2 microglobulin, these markers will suggest you towards poor prognosis than your good prognosis. Some receptors like HER2/neu, ER/PR, they will also guide us toward if the receptors are negative, the prognosis is bad. Then few tumor markers help us in monitoring the treatment. It will tell us the efficacy of chemotherapy or the residual disease after surgery. So in this category, we have CA125 for breast carcinoma, CA 19.9 for 19.9 for pancreatic tumor, CEA for all the epithelial tumor, alpha fetoprotein for HCC, hepatocellular carcinoma, beta HCG for your testicular or ovarian malignancies. Then detection of recurrence. For detection of recurrence, we have already discussed about CA125, which is the earliest to rise even before the radiological or the clinical symptoms. In this category, for breast cancer carcinoma, for recurrence, CA 15.3 is the marker. CEA, alpha fetoprotein, HCG, and PSA again are in this category. So what we learn from this overviewing the tumor markers, that no tumor marker is perfect, but every tumor marker has its own significance and has its own indication for the advice in particular patient. From the short and brief presentation of this tumor markers, the take-home message I would like to give is most tumor markers are present in normal, benign, and cancerous tissue and are not specific enough to be used for screening purpose. They are present in higher quantities in blood from cancer patient than in blood from both healthy subject and patients with benign diseases. Never rely on the result of a single test. Use multiple markers to increase the sensitivity and specificity of the diagnosis or guiding in your further investigations. Consider the half-life of a tumor marker when interpreting the test result during follow-up. Like for PSA, the half-life is quite high. So if you want to check the level for PSA to come down after your prostatectomy, then you have to check it for after 2 to 3 weeks and not immediately after the surgery. When ordering the serial testing, order it from the same lab using the same assay kit, because assay kit have different specificities and sensitivities and interfering substances. If you are using once 4th generation assay kit and once 2nd generation assay kit, it will give you or misguide you. The baseline tumor marker levels pre-operatively is important benchmark for follow-up. Thank you.
Thank you, Dr. Tejaswini. Really, your time management was perfect. It shows your degree in management. Thank you.
Thank you, sir.
Dr. Ajit Yadav is here. He will be speaking
Yes.
next, or Dr. Manan will be speaking next.
Sir, Ajit Yadav is here only. He'll using the same instrument.
So we'll introduce Dr. Ajit.
Yeah.
Dr. Ajit will be speaking on hematological tumor markers. He did his DNB in pathology from Apollo Gleneagles Hospital, Kolkata, and postdoctoral fellowship in hemato-oncology at Tata Medical Center, Kolkata. He also has done PDCC course in Department of Hematology at PD Hinduja Hospital and Research Center, Mumbai, with overall 5 years of valuable experience. That's a very short and sweet introduction, Dr. Ajit. Please go ahead with your talk.
Hello.
Yeah,
Yeah,
please go ahead.
am I audible? Am I audible?
Yeah, you are audible. Please go ahead, sir.
Yeah. Okay. So, good evening, everyone. Thank you for the opportunity for letting me present this one of the important topics of hematological tumor markers in malignancy. So, just hold on a second. I can't. I think you can see my screen now.
Not yet, sir.
Sorry.
Yeah, now we can see.
Now can you see? Okay, fine. So yeah, so going ahead, so what are basically the hematological tumor markers? So basically,
can you please put it in slideshow mode?
is not coming.
Right there on the upper side, left side. So that
Yeah.
it will show full screen slides.
Resume.
Or you can go ahead if it's not working.
You can bring the cursor to the presentation mode down below, and that would come as a presentation.
अजीत आप पहले ना शेयरिंग स्टॉप करके फिर स्क्रीन पे ले लो, फिर बाद में अपनी शेयरिंग करना.
Okay.
I think just double click will do the same trick. Full screen share.
New share.
See, any technician from LS Code will do anything? Huh?
F5.
Okay.
Okay, done.
Yeah, that's it. Thank
Sir,
you.
you can start your lecture.
Yeah, fine. So I'll go ahead. So basically, the hematological neoplasms they comprise of vast majority of diseases which are derived from myeloid or lymphoid hematopoietic lineages that contribute to significant morbidity as well as mortality. So, and differentiation of neoplasms is based on clinical presentation, morphology, and tumor markers that possess certain antigenic properties. So, what I want to, in this short presentation, I will highlight the important tumor markers, which are basically the antigens present on the tumor cells from the hematopoietic system. Okay, so going forward, I will just give you a short the classification of the neoplasms, which are basically myeloid neoplasms as well as the leukemias. So myeloid neoplasms, they mainly comprise of the myeloid MPNs or the myeloproliferative neoplasms, myeloids and lymphoid neoplasms associated with eosinophilia, MDS, MPN or dysplastic, or what we can say is dysplastic and proliferative neoplasms, and only MDS or myelodysplastic syndromes, which are now known as myelodysplastic neoplasms. Then coming to the AML, then acute leukemias of ambiguous lineage. Ambiguous lineage means we cannot differentiate them into simply into AML or ALL. And also the one of the common ones, which is the B lymphoblastic leukemias, lymphomas, and less commonly T lymphoblastic leukemias. So how these leukemias or the proliferative neoplasms or MDS, these are classified? So basically these are classified as I told you earlier, based on the clinical presentations of the patient, as well as the morphology, which is one of the most important entity. Then coming to the flow cytometry, from which we can distinguish the lineage of these cells, and later on we can just stratify them based on the techniques like cytogenetics or molecular studies. So, so this is the approach for diagnosis. As I said, first basically before morphology, we have the clinical presentation of the patient. Suppose if the patient is quite sick and quite ill, then it is more in terms of malignancy, it points more towards a leukemia or a high-grade lymphoma rather than any MDS or myelodysplastic syndrome or MDS MPN or a myeloproliferative neoplasm. Then after coming to the morphology, we decide what it could be. Could it be a leukemia? Could it be a lymphoma? Or could it be the myeloproliferative neoplasm? Based on that, we do a special test or special technique which is known as the flow cytometry. And after flow cytometry, we come to a diagnosis which type of leukemia or lymphoma it is, and we classify it. After classification comes the role of cytogenetics and molecular studies, where they provide certain the valuable information for according to which the risk strategy of the patient depends on, and later on comes the clinical management accordingly. So this is just a general classification for acute leukemia. I have classified it as you can see B lineage and T lineage for acute lymphoblastic leukemia or lymphoma. So leukemia, as you all know, leukemia means the presence of tumor cells in the peripheral blood, and if the tumor cells are confined to the lymph nodes or in the spleen or some other extramedullary site, can classify them as lymphoma. So B lineage, it consists mainly the main markers are 19, 20, 10, 22, 24, 79A, TDT. Out of this, CD19 is a pan B cell marker and TDT is a marker of immaturity. Then comes the T lineage marker. For the T lineage marker, we have CD2, CD1A, CD3. CD3 is the lineage specific. Then comes the CD4, CD5, CD7, CD8, and TDT. TDT comes in both B as well as T lineage, and it is an immaturity marker, as I said. Then comes the other type of leukemia, which is known as acute myeloid leukemia. So in myeloid, we have MPO 13, 33, 117, 15. Of which MPO is the most specific marker, and then comes the monocytic marker of the monocytic lineage, which has 14, 64, 36, 11B, 11C, lysozyme, and the other one is the erythroid marker. So we have an entity known as pure erythroid leukemia, in which the markers like CD71, CD235A comes positive, and the other one is the megakaryocytic or the acute megakaryocytic leukemia, which we say. And for that, we have specific markers called as 41, 30, 41, 61, and 36. So there is another rare entity known as mixed phenotype acute leukemias, in which we have both either of myeloid mixed along with B lineage, or myeloid along with T lineage, and the vice versa. So in this mixed phenotype, we have both myeloid as well as the lymphoid lineage markers, and hence it is known as mixed phenotype acute leukemias. And there is one more entity known as acute undifferentiated leukemia, where you cannot differentiate a cell into a specific lineage, whether it is a myeloid or a lymphoid or any other, or a monocytic kind of, because in that particular cell lineage, you will have mixed. You will not have any specific entity marker which will belong to a specific lineage. So this is another classification of lymphomas. So as you can see over here, there are two types of lymphocytes, basically B cells, T cells, and the other ones are the third one is the NK cell, or the natural killer cell. So there is another tumor marker, important tumor marker known as the kappa lambda light chain, on which we can decide whether this particular cell is of clonal entity or of monoclonal entity or of polyclonal entity. So if the cells, if the particular amount of cells, like 19 or B cells, they show both kappa as well as lambda. It means there are both populations of kappa and lambda light chain lymphocytes. Then they are generally polyclonal or panel. But if there are monoclonal, means there is only a single clone. Means a cell, a clone means a cell which is derived from a single clone, either kappa or lambda. Then this is known as monoclonal. So suppose if we get a case of lymphoma, which we know it is a monoclonal, then we further differentiate this type as CD5 positive or CD5 negative. Basically, we see two important markers, CD5 as well as CD10. So if the cell population, the tumor population is CD5 positive, and along with CD5 positivity, we get CD200 positive, CD23 positive, CD20 dim. Then we classify it as chronic lymphocytic leukemia, which you all know, which is the commonest lymphoma, which we see in the peripheral blood. And the other one, if the morphology of the cells are like a blast, or what we say is blastoid cells. If these cells are CD5 positive, CD200 negative, 23 negative, then we classify it as mantle cell lymphoma. Of course, other markers like SOX11, those or cyclin D1 positivity, those are also seen in mantle cell lymphoma, and we advise them accordingly. So all this classification does not, the entity of the diagnostic entity doesn't depend actually only on this flowchart. It also depends upon the morphology as well as on the clinical presentation of the patient. Similarly, for the T cells, surface CD3 is the T cell marker, and we also have TCR alpha, beta, gamma, delta, but I will not go into much detail because these are relatively rare entities. Yeah. Okay. So and another B cell lymphoma, which is also quite common. You can over here in our labs I have seen the entities, which is hairy cell leukemia. So it also has a specific pattern, like it has a monocytopenia, and it will have the morphology will have some hairy projections. Okay, the patient will have massive spleen, and when we do a flow on this patient, we will get a particular pattern is CD5 negative, 10 negative. These say 103, 123, 11C, 25 positivity, which will classify this as hairy cell leukemia. And there's another type known as the splenic marginal zone lymphoma. Basically, in this marginal zone lymphoma, all the markers except 19 and 20, they come out to be as negative. 23 might be positive, but most of the time it is negative. And with the morphology and clinical features as well as the flow cytometric findings fit into that, then we can classify this as marginal zone lymphoma. If the patient has splenomegaly and if the morphology is of like showing some villous lymphocytes like that. So along with markers, the other entities are also important to classify them as leukemias or lymphomas. So this is the another basically this is the same classification, and I have added this maturity and NK cells. I will not go into much detail. So this is the flow cytometry machine, Beckman Coulter. This is Nebius. This is a 10-color flow cytometry instrument in our lab on which we do the immunophenotyping. And these are the panel of markers, as you can see over here. So you can see, just hold on a second. Is my screen visible? I'm sorry. Okay. So you can see we have a variety of panels for leukemia as well as for the lymphomas. Lymphoma, CLPD is nothing but chronic lymphoproliferative disease panel. And in this panel, you can see in the leukemia panels 13, 34, 10, 95, 45, 117, 20 HLA-DR. So we mix all both B as well as the myeloid as well as some T cell markers like CD3. Okay, sometimes CD4 if we require. So we mix the markers, and according to the pattern which we get, the positivity of the markers which we get, we classify them as myeloid or lymphoid, like that. So this is the secondary panel where you can see CD41, 61, 42B, CD8, 4, 2, 1A, 11B. So so these are basically for the megakaryocyte markers, the T cell markers, and you can see there are some erythroid markers also, CD73, the CD138. This is specific for the plasma cells. So in the next is the CLPD panel, where we have kappa, lambda, 38, CD19, CD5, 45, 49, D20 in the first tube, and in the other tubes there is CD200, CD10, CD19, 45. 200 basically comes mainly in the it is strong positive in CLL, and it's moderate positive in hairy cell or splenic marginal zone lymphomas. And there is another third tube, CD103, 23, 25, 11C. So this is specific for hairy cell the leukemia. So whenever we have a strong suspicion for HCL or hairy cell leukemia, we add up this third tube also. And there is another secondary panel which comprises of T cell markers like CD2, 8, 4, 1A. If we have a T cell, if we suspect the T cell lymphoma, along with CD34 HLA-DR. CD34 HLA-DR, as we all know, these are the maturity markers. So another panel, we have the MRD panel, that is the minimal residual disease panel. So what is minimal residual disease? Basically, if a patient is a known case of any leukemia, like suppose a B cell leukemia, T cell leukemia, or AML, so after treatment, after the 30 days, which is known as the induction therapy, or after like 70 days, which is known as the consolidation therapy, what is the are there any residual tumor cells present in the bone marrow? So to check that, we perform the MRD panel, or the minimal residual disease panel. So we acquire more number of events or more number of cells, and we see whether there is any the residual abnormal the tumor population present in the bone marrow sample of the patient or not. So we along with the diagnostic panel, we also have the MRD panel, and plus the myeloma panel. So myeloma panel, this is generally basically for the patients of multiple myeloma. So where we have cytoplasmic kappa, lambda, 117, 45, CD19, CD20, 138, 38, HLA-DR, all these kind of markers in the first tube. And in the other tube, CD81, 34, 38, 45, CD19, 20, 56, CD200, HLA-DR. So depending upon the suspicion of leukemia or lymphoma bias, we put these panels accordingly. And for this, for your information, for diagnostics, if these tumor cells are around 50 to 60%, 20 to 40 to 50 to 60%, there are enough number of tumor cells in the peripheral blood, then the peripheral blood will do for diagnostic panel. But if the amount of the blast or tumor cells are low in the peripheral blood, then we generally advise the bone marrow of the patient, and and we do the flow cytometry from the bone marrow then accordingly. But for the MRD panel, or the minimal residual disease panel, if a clinician asks for the MRD panel, suppose if a hematologist asks you for MRD panel, then it is obligatory for us to have a bone marrow sample, because bone marrow sample will be essential for the MRD, because in the peripheral blood, even if we don't get any abnormal cells, it is not that in the bone marrow aspirate or in the bone marrow aspirate sample there won't be any tumor cells. So that's why bone marrow sample is essential for minimal residual disease. Otherwise, if the tumor cells are adequate for diagnostics, then in the peripheral blood, then the peripheral blood will do. So apart from the tumor markers, we also have another markers, EMA binding assay. So basically, this EMA binding assay is to diagnose hereditary spherocytosis. We have the EMA dye over here, and platelet assay, as I've discussed. We do also do HLA-B27 over here with markers like B27, B7, and CD3 for T cells. We have CD4, CD8 count panel, and only CD19, 20 count. Okay. Or NK cell. Suppose if the clinician wants to know the NK cell count in the peripheral blood of a certain patient, then we have CD16, CD56, CD7, CD3. Other panel, we have lymphocyte subset analysis where we have a couple of markers, like 19, 20, 45, and T markers like CD3, CD4, CD8, 16, 56, 45, where we can find the B cells. We can separate B cells, T cells, as well as the natural killer cells or the NK cells. Then the other important panel what we have is the PNH, or the paroxysmal nocturnal hemoglobinuria. So to diagnose a PNH, the flow cytometry is a must. Okay. So for that we have markers. Important marker like CD157, CD55, CD59, flyer, CD33, where we get the monocytes, and CD45, CD64, as well as sometimes we can use CD24 also to get the granulocytes or the neutrophils. So just to some prognostic markers for CLL, I'll just discuss in short. Because CLL is a common tumor which we get, we must know certain things about it, like rapid lymphocyte doubling time in 12 months, or elevated beta 2 macroglobulin levels, CD38. If in the flow cytometry we find CD38, CD49D positivity, or SAP70 by molecular studies, or there is a complex karyotype, then it indicates a worse prognosis for the patient. On the other hand, if there is a IGHV mutation in the molecular studies, there is a mutation and analysis for variable chain, for immunoglobulin heavy chain variable. If it comes positive, then it has a favorable outcome. Or if the patient has deletion 13q, then also the outcome is quite favorable. Then for multiple myeloma is also one of the commonest malignancies we can get. So whenever a patient or hematologist or any other doctor advises for multiple myeloma panel, then there are certain things like serum beta 2 microglobulin levels, like protein electrophoresis, immunofixation studies, and free light chain assay. So these four things are essential to know whether there is a monoclonal protein present or not. And if the patient is already a diagnosed case of multiple myeloma, and if he's on follow-up, then even free light chain assay and this one, the immunoglobulin levels, means initially suppose.
Sorry to interrupt, sir. 2 more minutes, please.
Sure. I'll just complete in 2 to 3 minutes. So if the patient is was known as IgA kappa or IgA lambda positive, then only the free light chain assay as well, and the immunoglobulin levels for IgA or any the diagnostic, whichever diagnostic marker was possible, that will do. So that we must remember. So for this is just a staging system. I will not go into details. Time is less for me. So this I have discussed, and this is basically risk stratification, which I think Dr. Manan might introduce you. So this is my short presentation. If any queries you have, you can ask me. Thank you.
Thank you, Dr. Ajit. We will take all the queries at the end of the session. Let us go ahead with Dr. Manan Patel's presentation now. To introduce Dr. Manan Patel, he is working as a consultant genetist with Sterling Accuris. He will be speaking on molecular tumor markers. He did his PhD from IIT Madras on the subject of molecular biology. Later, he joined Gujarat Biotechnology Research Center, where he worked on oral cancer markers. He has several peer-reviewed publications, patents, and national international conference presentations in the field of genetics and molecular biology. That's impressive, Dr. Manan. Please go ahead with your talk.
Thank you, Dr. Madhusudan ji. Am I audible?
Yeah.
Okay. So good evening, beloved audience. I can see Dr. Piyush Patnaik is also present from Sterling. He is a VP, and I would like to thank Dr. Tejaswini and Dr. Ajit for briefing on biochemical and hematological markers. So after that, it comes the molecular markers. So I would like to share a brief on
Sir,
molecular.
voice, please.
Sorry?
Voice, please.
Oh, sorry. One second. So is it clear now?
Hello.
Hello.
Yeah.
Yeah, is it clear now?
Yeah. Got it. Okay.
Okay. So I will just share my screen. Just a second.
And make it full screen. Huh? Yeah. Okay.
Yeah, it's a full screen, right?
Yeah. Yes.
Okay. Okay. So I'll go ahead. Uh, So first of all, what is molecular diagnosis? So here basically we are actually going where the problem is. So the problem arises from DNA, which is our genetic material, and later that problem multiplies to the protein. So DNA becomes RNA and RNA becomes protein. So a single molecule of DNA can code thousands of protein, and this particular defect in the DNA can lead to multiple defected protein molecules which can basically give rise to this kind of cancer. So the molecular diagnosis is where we are using just a second, I will turn on the pointer. Yeah. So molecular diagnosis is where we are using a sequence specific information in the macromolecule. As doctor correctly mentioned, for diagnosis, for prognosis and risk identification, for targeted therapy, monitoring the therapeutic response of a particular drug, and the prediction of the response to the therapy. So these all things are achievable with the molecular markers, and I will show them with the example of different markers. So macromolecules are basically polypeptides, polysaccharides, polynucleotides. We are barely exploring currently the DNA and RNA, which are polynucleotides. We are rarely using polypeptides and polysaccharides in our study as sequencing information from polysaccharide and polypeptides. So that avenue is yet to be explored in the diagnostic field. So this is just to brief you this is the data from Global Cancer Observatory, and the lung, prostate, and colorectal are the leading cancers in the males, and of course breast cancer and the colorectal and lung are again leading cancer in the female. But if we see the scenario of India, it's a bit different. The leading cancer is male is lip and oral cavity, and if you see this lip and oral cavity cancer also the fourth ranking cancer in the female because of the obviously the overconsumption of tobacco. And here, if you can see, there is a higher incidence of cervical cancer also due to poor hygiene in many of the village area. And unluckily, or we can say there are very limited markers available for at least lip oral cancer, either in the biochemical or hematological or molecular stage. And there is a bare need to develop more marker, and more research is going on. So basically, the molecular test or the diagnosis pipeline from morphology to molecular. So when it comes to molecular testing, we have for oncology, we have two broad categories, that is hematological malignancies, most of which Dr. Ajit has covered. And we have solid tumors where all the other like breast cancer, prostate cancer, pancreatic cancer, other cancer lies, and the incidence rate is much higher than the hematological malignancies. So the flow of the study is obviously there is a clinical data, biochemical finding, morphological features, and after that the hard work lies in the defining the disease through bone marrow biopsy, its morphological evaluation and immunophenotyping. which Dr. Ajit has covered. Once the disease is defined, there are particular molecular markers which are to be studied according to the disease. So supposingly if it is a CML, chronic myeloid leukemia, then first thing we will study is whether there is a translocation of from chromosome 9 to 22, that we call the BCR-ABL test. So similarly for solid tumors also, the initial investigation starts with the biochemical and radiological finding. Then there is a biopsy analysis and then the immunohistochemistry, which defines the particular type of tumor. And later, once that all workup is done, the molecular study plays a role in defining the targeted therapy or the risk stratification. Apart from that, there is another avenue which is becoming fairly popular in last 10 years is those who have the family history. They are screened for particular mutation. This is especially important to manage the breast cancer, that the BRCA testing has almost placed the breast cancer worldwide in the first category because of screening is increased. So the BRCA1, BRCA2 testing in family history is becoming important. That is one of the molecular marker, and the mutation in which can put the patient at higher, much higher risk than the non-mutated one. So for them, the genetic counseling is advised, and further they are opted for molecular study. So before going into the actual molecular markers, I just want to brief you about techniques or the methods we use in the molecular diagnosis. So the classical method are karyotyping and FISH. So here we are using a particular fluorescent probe to target a gene. Real-time PCR, sequencing, MLPA, fragment analysis, micro or NGS, these all are advanced techniques which we are using. So just to illustrate them, karyotyping, see if karyotyping is if I want to have I want to find out there is any defect in the books lying in the shelf, then I would opt for karyotyping, because karyotyping give me the overall picture whether there are books are torn or something. Then if I want to go to particular page, whether any page number is changed or it is whether 1 and 22 are interchanged page number, then the fish and micro helps me because these are going in the better depth. So this is a particular image of fish where HER2 marker is positive. So you can see HER2 is amplified. HER2 is where we are targeting a particular gene. So HER2 is targeted with the red color probe and centromere 17 is targeted with green color probe. So this is actually how we analyze the data and we count this marker, and there is then the backend calculation, and then we give the report as positive or negative. And now going into the further depth where I want to see a particular spelling mistake, then I will use a PCR, Sanger or NGS. So PCR what it will, or Sanger what it will do is whether any particular nucleotide change is there or not, that it will tell me. So with the help of PCR and Sanger, I can say analyze 1, 2, 3 or 4 pages. But with the help of NGS, I can analyze entire book. So that is the power of NGS, but there are always limitations also. So all technique has its important at its core, and different techniques are used. Now, when it comes to molecular marker, the classical example is BCR-ABL testing in the case of chronic myeloid leukemia. So this accounts for obviously 20% of all leukemias, and where the major mutation is a translocation between chromosome 9 and 22, where part of the chromosome 22 and 9 are interchanged. So that we can see here, this is a chromosome 9 and this is a chromosome 22. So its part is interchanged, and the same thing we can also see in the karyotyping and at higher resolution at the fish. So because it is interchanged, we will get these two fusion signal and two individual signal. If it is a normal, then we will get only two red signal and two green signal, but this fusion signal won't be there in the normal case. So this is an example, this is a classical example because not only it confirms the diagnosis, but there are guidelines where we are also monitoring this BCR-ABL gene on regular basis. Say every 3 months or 6 months, the patient has to do the BCR-ABL testing, and depending upon the percentage of BCR-ABL, the patient is defined into certain category where we see a response to a targeted therapy, where this imatinib was the first approved targeted therapy for this kind of patient. And before this, the patient had only the option of supportive care and hypoxuria, interferon, that just a palliative care were available. So this has revolutionized the therapy in 2001. But again, when there is a deep molecular response, the TKI therapy can also be stopped under a particular care. And so particularly patient is on constant monitoring of BCR-ABL. And one important thing to learn here is 1 of 4 patient with CML become resistant to the drug. So that also we have to find out. So again, there is a guideline that if there is a 3 month, 6 month, 12 month, and more than 15-month time period is there, and this is a BCR-ABL level. So if it is less than 1%, then there is no issue. If it is more than 1% to 10%, either the patient is in yellow or red, or if it is more than 10%, depending upon the timeline, patient is in the red zone. So if it is the patient is in the red zone for more than 3 to 6 months, then we have to check for particular mutation which is inhibiting this drug. So that test is called as IRMA, imatinib resistant mutation analysis. So this is a classical example where we are confirming diagnosis, prognosis, disease monitoring, and targeted therapy. So this particular marker is very important. Similarly, there are multiple markers for risk stratification. Say, for example, in AML, patient can be categorized into favorable, intermediate, or adverse risk, depending upon the different type of markers which are either positive or negative. So there are several translocation 821, inversion 16, NPM1 mutation. These all are favorable markers. If these are found in the patient, then patient will be in favorable phenotype. If this particular category is found, it is an intermediate, and similarly, if translocation 619 or translocation 922, which is BCR-ABL, again is found, then it is an adverse condition. So, and not only the risk stratification, the patient new therapies are coming. Say, for in the same case of AML, these are the list of FDA approved targeted therapy, where this particular anacitinib can be was first approved therapy for IDH2 mutation. This is again for IDH1 approved IDH1 mutation positive patient, FLT3 mutation positive patient, CD33 positive patient also there is a targeted therapy, and lastly BCL2 positive patient, venetoclax therapy is recommended for patient more than 75 years of age. So these are just the list of the tests only for AML. So we have again the test for CML, MM, multiple myeloma, CML, ALL, CLL. So this is how the comprehensive profiling on NGS looks like, where we study, this is a panel for leukemia, lymphoma, and myelodysplastic syndrome. So there we study multiple hotspot genes, full genes, then fusions, expressions of certain genes. So these are the individual marker. If I categorize them, I can place them in under each bracket, where you can see, for example, for polycythemia vera, Z2 is very important. Essential thrombocytopenia, PMF. So this is a comprehensive study where there are rare chances of getting this marker positive. But since it's a comprehensive test, it study all of it. So these are the fusions covered under that panel. So these are the fusions for AML, these are for APL, these are for BLL cases where 922 and T1221 are very important. Eosinophilia, PDGFRA, PDGFRA-B rearrangements are very important for deciding the treatment. So this is again for CLL, as Dr. Ajit mentioned, beta-2 microglobulin and Z70 are biochemical markers. Along with that, there are at least one in, if for 80% of CLL patients carry one of 4 common chromosomal aberration, that is deletion 11, deletion 17, deletion 13, or trisomy 12. These all are covered by our FISH test. Again, there are these all are combining our prognostic marker, and there are also predictive marker which are TP53 gene. So disruption or mutation in TP53 gene associated with chemoimmunotherapy failure of for certain drugs, and mutation status of IgVH. If IgVH is positive, then it is benefiting certain immunotherapy agent. So this all information we can get from this kind of molecular markers. So as far as it comes to solid tumors, NSCLC, that is non-small cell lung cancer, adenocarcinoma, there EGFR plays a pivotal role because one of the Indian study, it is there where it shows that approximately 50% of patients are EGFR positive. And this is just a mutation. This E represents exon in which part of the gene this mutation is positive. So there are targeted therapy available for exon 19 as well as exon 21. So which covers almost more than, I think, 85% of the mutation present in EGFR. So this EGFR particular mutation is very important along with this KRAS, UL, cross fusion, everything we study, HER2 mutation also we study. These all are molecular markers for NSCLC lung cancer. So this is just a list from a paper of 2021 where they have mentioned different type of FDA approved indications for different type of cancer. So as you see, it can include it's including lung cancer, melanoma cancer, breast, ovarian, pancreatic, prostate cancer. GIST kit is very important. Breast cancer, again PIK3CA is important. PDGFR is important in again GIST. So there are colorectal cancer, KRAS is targeted therapies available. So basically there is ever growing agents are also in the development where more and more targets are being met with their targeted therapy. So this is very important. So this is just a list of molecular marker which we study through either PCR or FISH or NGS method. And this is a comprehensive NGS analysis looks like where we study almost all the markers, all the rare mutations where we cannot target each particular gene individually because their frequency of mutation is very less, but it will be covered in this kind of comprehensive panel. Just the last slide where the importance of hereditary cancer I just want to show. So people who have inherited mutation or a pathogenic variant in a cancer susceptibility gene are at significantly higher risk of developing certain type of cancer. So for example, BRCA1 mutation, there is a 45 to 85% lifetime risk of developing breast cancer. And if a mutation is not there, the lifetime risk is only 12%. So at least you can see there is a fourfold rise in the developing a breast cancer. So continuous effort from the government and also pharmaceutical companies are there to screen majority of families wherever possible. There is a family history and tackle this disease at its earliest stage. So again, we have a hereditary cancer panel which covers 143 genes which are responsible for various type of cancer and the mutations are studied accordingly. So just to end my presentation, I just want to quote a very famous quotation by Charles Darwin that it is not the strongest of the species that survive, not the most intelligent, but the one most responsive to change. So we are also changing kind of, because I feel that this is a stage where diagnostic and medicine and treatment, everything is revolutionizing at the highest pace world has ever seen. So we are also coping with that. And I just want to leave you with a question that you can search on the Google that how long is DNA molecule from a single cell. So you may have heard many times how big is our genome, but this also is very interesting thing you will find. So that's all from my side. I will like to take any questions from the audience.
Okay.
Thank you, Dr. Manan. I think Dr. Mahadev sir had one question. Mahadev, are you there?
Yes, sir. The question is that is there something like UCOM, universal cancer only marker? And if it is so, is it available or when it will be available? Hello.
Sorry, sir.
The question is there anything like UCOM, Universal Cancer Only Marker? Is there any this sort of marker is there? And if it is there, then when will it be available in India also? UCOM,
Okay.
Universal Cancer Only Marker.
So currently, whatever markers which we are studying, they are very specific for particular cancer type. So as such, there is nothing like universal cancer marker. But the thing is, there are practices where we take the blood and we check the circulatory DNA, which is arising from cancer cell. So these cancer cells are dying and growing at very high speed. So they have a tendency to release certain DNA molecules which are cancer specific. So there are tests available, but it is not on the open forum. Rather, they are currently used as a monitoring purpose. But in future, they may come for diagnosis purpose also with more sensitivity if it is there.
Now,
What you
see,
mentioned,
next question is what we learn from this today's webinar is that this biochemical marker are inspiring this PSA, all are for this therapeutic and for staging diagnostic. But if suppose a patient of age of 50 or 45 or 55 is getting everything annual health check every year, and then what marker he or she should get it done, and is there any specificity if suppose that marker is rising annually or something like that? Is there any relevance for it?
Sir, I would like to take this question. So definitely there are few things, but ordering just the markers and not seeing the patient will not help. Yes, you have to examine the patient. If she has the breast lump, then you have your markers. If the patient is male, more than 50 year or more than 40 years with a history of prostatic cancer in the family, yes, you have the marker. If the patient on sonography, abdominal sonographies are included in your packages and all, and the patient is having pancreatic shadow, then yes, you have the marker. If the patient is showing on sonography showing ovarian mass, yes, you have the marker. Directly going to the marker is not the answer, but yes, after examining the patient, after doing few regular things which should be done on a yearly basis after certain age, after that, yes, if you have something, you have a biochemical marker which will help you to decide whether to go for further investigations and or not. Yes, we can definitely navigate or guide clinicians for that. If the levels are very high, then yes, you can think of even going for the invasive biopsies on even MRIs, and going in detail for which tumor it is, how much it is big, and activity and other things can be followed. If the levels are marginally increased, just like CA 125, you have cutoff is 60 and you are getting 90 value, then you should go for whether the patient is menstruating, whether she has history of abdominal cramps or anything related to endometriosis. In few of the endometriosis patient, we have seen CA 125 up to 400. So but in malignancy it is in thousands. So definitely we will guide you, but definitely we will not put the patient or diagnose the patient only on markers, but the physicians, the basic investigations, and this add-on investigation will definitely help you to differentiate those special people who will need further investigations.
Thank you, Tejaswini. So what we understand now is that being a physician or family physician, you should know everything, the first history, then clinical examination, so certain radiological investigation. If you suspect, then you go for the marker to add on marker. That is the take-home message, I think. And Dr. Madhav, do you want to add anything?
Yeah, surely. I feel that as Dr. Tejaswini has rightly said, except PSA, probably no markers are required for the as a screening part. But what we can add clinically is if the patient has anemia of unknown origin, or if patient has altered bowel habits, it's better that we go for stool for occult blood. And if it is persistently positive, maybe we go for colonoscopy, because that is what we find the most common masquerading illness, malignancy in most of our patients. So I would strongly suggest for fecal occult blood, that is one, and if required, colonoscopy. And the markers come mainly once the diagnosis is done for the prognosis as well as the response. But otherwise, clinically for us, really most is important is PSA, and in family histories of CA breast, maybe we go for BRCA1, 2.
So thank you, Madhav bhai, and thank you all the speaker for enlightening us about this tumor marker and helping us to acknowledge our knowledge. Our next CME will be on the 22nd of February, that is third Thursday of the February, and the topic will be decided later on. Most probably, it will be in continuation with this health checkup. We may take either radiological, like this CT, angio, and calcium score or something like that. So thank you all till 22nd February. Thanks, and we conclude this session.
Thank you, sir. Thank you for the opportunity.
Okay.
Thank you, sir.